Good evening, one and all. On behalf of Dr. Agarwal's Institute of Optometry, I extend a warm welcome to each and every one of you for the 44th episode of Optometry series. So today we're going to discuss about the part 2, back to basics. And the topic for today is we're going to discuss more on the color vision test. So Anshi ma'am, thank you so much for joining with us today, ma'am. Meenakshi, thank you so much for joining. So Anshi ma'am, so who is our today's moderator, ma'am?
So we have Dhavamathi with us. She is an excellent clinician. And as I said, we are going back to the basics of understanding optometry. So we finished our first episode and the second episode is with color vision. So I'm very much happy that she's able to give us time and explain about and give us inputs on what are the different types of color vision procedures and how we can document them. Because just doing a procedure is not something, but understanding the nuances of what the procedure is giving us. I think Dhavamathi is a very good person to explain. So thank you so much. Even though you're traveling today, for taking out time and saying yes for the series. So we'll just have an introduction about Dhavamathi. Over to the MC, please.
Over to you, Divyadashini.
Good evening, everyone. I'm Divyadashini, a second year Bachelor of Optometry student at Dr. Agarwal's Institute of Optometry. I'm delighted to welcome today's moderator, Ms. Salai Dhavamathi. Ms. Salai Dhavamathi is an assistant professor, senior scale, and is currently pursuing her PhD in the Department of Optometry at Manipal Academy of Higher Education. She completed her undergraduate studies at the Elite School of Optometry and a postgraduate degree at Amity University. Ms. Dhavamathi has extensive experience in both clinical practice and academic teaching. Her research interests include myopia, pediatric optometry, and alternative medicine. She has been actively involved in assessing and treating children with special needs in collaboration with the Udupi Samagra Shiksha School for Disability. In recognition of her contributions, she received the Best Educator of the Year award from the Optometric Confederation of India, supported by Bosch and Lomb in 2024. Additionally, she is honored with the Young Leadership Award by the Indian Vision Institute in 2018. Ms. Dhavamathi has also presented oral and poster papers at various international and national conferences and several publications to her credit. Thank you so much for joining us today, ma'am. Now let us welcome today's presenter, Ms. Renose, who is currently pursuing her second year master's in optometry at Dr. Agarwal's Institute of Optometry. Ms. Renose, please begin your presentation.
Priya. Good evening, ma'am. Hi, I'm Renose. My topic is back to basics part 2, color vision testing. Color vision testing is an essential diagnosis tool used to identify the color deficiency. It's purely based on the sensory pathway. And we assess the color vision cone cells are in the retina. It distinguishes the color. Deficiency can arise due to the genetic factor or acquired conditions such as optic nerve or drug toxicities. It play a pivotal role in the both clinical and occupational settings. For example, they are indicated in assessing fitness for profession, in navigation and electrical works. Electrical works where precise color discrimination critical. Types of color vision testing. So the isochromatic plate. In isochromatic plates, Ishwarya plates and American Optical 8 HRR plates, standard pseudo isochromatic plates, and CT University testing. In isochromatic plates, we identify the red and green deficiency. American Optical HRR test, we also identify the proton, deuteron, and titan coloration deficiency. Standard evaluation for both specific Ishwarya and HRR testing. CT Union testing is if we are aware with the occupational setting. Anomaloscopes, Nagal anomaloscope, ocular Hutchinson anomaloscope, night anomaloscope, and Wikifort Nicholson anomaloscope. The gold standard one is Nagal anomaloscope. And it's a circle. It's in circle. In lower part will be yellow, and the upper part will be the red. We consider the yellow. And Nagal anomaloscope similar to the Nagal anomaloscope. Similar to Nagel, but uses advanced technology like multiple wavelength, night anomaloscope, focus on the testing bone function in red, green, and blue and yellow pathway. Pickford Nicholas anomaloscope is less common tool used in the research. Arrangement set. Postman means a 100 root test. It helps identify the both and congenital acquired color vision deficiency, commonly used for occupational screening and clinical diagnosis. Once for T15 test, a simplified version of FM100 test involving 15 color caps, used to identify moderate to severe color vision deficiencies. Last one, descended D15 test, similar to the D15 test but with less saturated colors, making it more sensitive to mild deficiency. It is particularly useful in detecting acquired deficiency due to disease like glaucoma or optic neuritis. Adam desaturated D15 test, a variant of D15 with even more subtle color deficiency, designed for more detailed occupation and clinical evaluations. Latent tests. Latent tests are used to assess the ability to distinguish between the specific color under similar signal conditions. They are theoretical for professions like aviation or maritime roles where color perception affects safety. It is being latent, designed to test the ability to distinguish between the different light signals. Often used in railways and maritime industries. Transport latent tests. Presence pairing of colored lights that must be identified by the practitioner, commonly used by the US military to evaluate the color vision for pilot and navigators. Primarily seen for red and green deficiency. Amlo switch lantern, a clinical and occupational test for color vision used in aviation, mimic real life signal colors, testing accuracy under colored controlled lighting. Maritime lantern. Yes, specialized test often used in military and maritime setting, focusing identification of red and green, white lights. Types. Trichromatism. Three primary colors in appropriate proportion. Will match any preserved colors. Normal trichromatism, maximum phototropic luminosity at 550 nanometer, and anomalous trichromacy. Photoanomaly, phototropic sensitive for red wavelength in low. Maximum luminosity 540 nanometer. Require more red light in color match of red and green to match a standard yellow. Deuteranomally, photopic spectral sensitivity nearly normal, required more green light in colored match of red and green to match the standard yellow. Tritonally, photopic specular sensitivity is normal, required more blue light in the mixture of blue and green to match the standard cyan. Titanomism, two primary color in appropriate proportion will match any preserved color. Photonophia, photopic sensitivity to red is decreased. Red are often confused with black. To the peak at 540 nanometer, the neutral point is at 594 nanometer. Wavelengths longer than the neutral point may allow appear to be the same or to be differ in the saturation and brightness. Red, orange, yellows, and green are frequently considered. Wavelengths shorter than the neutral points are seen as blue. Deuteranopia, phototropic sensitivity is nearly normal. Luminosity peak at 560 nanometer. Neutral point is at 599 nanometer. Red, orange, yellow, and green are frequently confused. Wavelengths shorter than the neutral point are seen as blue. Titanopia, phototropic spectral sensitivity is normal. The neutral point is at 570 nanometers. Monochromatism, all portions of the visual spectrum are seen as gray of differing brightness. Vision is achromatic and all preserved color can be matched by adjusting the intensity of any single color. Broad monochromatism, typical achromatism, autosomal recessive, and cone monochromatism, atypical achromatism. Executive red and green color vision anomalies are inherited as X-linked, sex-linked chromatisms more common in males, and male color deficiency, male receives the defective gene from his mother, who is typically color normal. For a female to be color deficient, she is much receive the defective gene from both her father and mother. Acquired color vision anomalies can be caused by the disease of choroid and retinal optic nerve. Lesions of the choroid tend to cause the yellow-blue anomalies. Retinal lesion cause either yellow-blue or red-green anomalies, and optic nerve lesions can cause the red and green anomalies. Acquired color deficiency and their clinical causes. It classifies three types. Type 1, red and green. It's similar to photon defect wavelength of maximum illumination efficiency displaced to the shorter wavelength. In clinical association, progressive cone dystrophies and chloroquine toxicity. Example, target disease. Type 2, red-green. Similar to the deuteron defect, reduction of relative numeraries efficiency for short wavelength. Clinical association, optic neuropathy. Example, retinobulbar associated with multiple sclerosis. Asymptomatic toxicity. And type 3 blue, most common, similar to the titan defect with a reduction of relative luminance efficiency at both spectral limit with the displaced retinal luminance effects to sharper wavelength pseudo-photometry. Clinical association, progressive rod disturbance, retinal vascular lesions and peripheral retinal lesions. Example, retinitis pigmentosa, diabetic retinopathy, and glaucoma. Macular edema. Example, central serous retinopathy, diabetic maculopathy, age-related macular degeneration. First, we see the pseudochrysochromatic traits. Based on the principle of confusion pigment colored in red and green color efficiency, what describing normal color vision. Normal trichomonas can see number on the all page except a hidden digit. In this picture, we see the left side, the normal patient will see all the numbers, but the red and green deficiency will see the few charts only. And design and function of pseudochromatic glasses. In this five types of charts, a demo or introduction chart, transformation and vanishing, hidden digits, and classification. Plate 1 is the demo, and 2 to 9 charts is the transformation part, and 10 to 17 is the vanishing chart, 18 to 21 is the hidden chart, and 22 to 26 is the classification chart. Demo chart will see corrected by all subject, and transformation chart only. And number seen by the color normal appear differ to the color deficiency subject. The vanishing chart, a number is seen by the color normal but cannot be seen by the color defective subject. Hidden chart, the number cannot be seen by the normal but is seen by the color deficiency subject. Classification types of deficiency. Red or green is obtained from comparing the relative contrast of the paired numbers. In literature, we can use the pathway chart. Advantages of pseudo-isochromatic rates and an effective staining test for red and green color deficiency. It provides quick and simple measurements. Disadvantage of isochromatic rate. It is designed around the normal and abnormal boundaries to grade the severity of congenital and acquired color deficiency for monitoring acquired color defects and detecting blue-yellow defects. The color of Ishwarya plates can fade over time, affecting the test validity. Procedure. Adequate illumination. Start monocularly with correction. Testing distance 75 cm. Out of initial 21 plates, 17 plates or more read correctly if normal. 13 or less, it can be the red and green color deficiency. Plate 22 to 25 are for differential diagnosis for protons and neutron defects. Patient can 4 or fewer errors is normal, it's acceptable. Interpreting chart. The normal patient can read the in chart. If the person has the red and green deficiency, will interpret the wrongly numbers. Documentation. In right eye, OD 25 by 25. In the left eye, 25 by 25. If patient read 5 chart, then record 5 by 21. Haddy Route written HRRT is the test choice for the quantitative diagnosis. Standard pseudo-isochromatic rate value 2 for acquired color deficiency. In this state is like the pseudo-isochromatic rate. In this chart, denote the circle, triangle, and X. Nagel anomaloscope. Based on the Lilac equation, a yellow hue is obtained by mixing the red and green color. A source of white light which is feeding into the spectral colors by the prism in the in a circular split field, circular bipartite field, test 2 to 3 degree foveal cones. Procedure. Viewing setting. The patient looks through the eyepiece to view the circular field divided into a two halos. The lower half display a fixed yellow light. The upper halo presents a mixture of red and green light, which the patient can adjust using knobs. Thus, the patient is instructed to match the color into the two halos by manipulating. Knob 1 adjusts the ratio of red and green in the upper half. Knob 2 controls the brightness of the yellow light in the lower half. The goal is to achieve the preserved color and brightness match between the two halves. Diagnosis. The device records the setting where the patient preserves their match. Normal vision. A match typically occurs in the mixture of 14 to 15 units of red, green, and the 15 units of yellow. Deficiency. Deviation from this value indicate the type and the severity of color vision deficiency. Environmental condition. The test is performed in the semi-dark room environment to eliminate the ambient light interference that ensure the accurate perception. Significance in color within a specific range. Demonstrate typical trichromatic vision. Individuals with a proton anomaly, red deficiency, and neuton anomaly, green deficiency adjust the knobs differently, revealing the altering position of the color pictures. Anomalous quotient. Calculate an individual's observed match relative to the mean of normal observers. Normal trichromatics fall between about 0.74 to 1.4, Newton anomaly 1.7 to 20, extreme Newton anomaly 1 to infinity, proton anomaly 0.11 to 0.6, extreme proton anomaly 0 to 1, protonopia, a very yellow light is matched to green endpoint and the very dark yellow is matched to red endpoint. Newton anomaly, the both red endpoint is matched with the brightest value around 15. Interpretation. Patients see the yellow light in the lower part and the upper you have the red and green. Patient to match the red or yellow and yellow. If suppose the patient and the normal value of the color vision is the 14 to 15 red and green and the unit of 15 units of yellow. In the mean normal value is the normal. If the patient is leads to the green side, the deuteranopia, patient has a deuteranopia. If the patient leads to the more than 50, has the protonopia condition. Advantages of the advantage excellent test for the screening, classification, and grading color vision deficiency. Disadvantages expensive and comparatively difficult to administration. Wordsworth-Nielsen 100U test 85 movable color samples. They are numbered on the back according to the corrected color of the hue, and the scored sheets are provided. Observer is instructed to arrange the caps as per hue variation, taking first and last fixed caps as reference. Further, illumination. Proper lighting is theoretical as the color temperature of the illuminator significantly influence the appearance of the test color. Use standardized light conditions such as the daylight equivalent illuminated CIC, standard illuminated C, or D65. Always assess color vision monopoly to detect any asymmetrical vision perception between two eyes. Ensure patient wearing appropriate near vision correction reading glasses during the test. Avoid the use of tinted spectacles or contact lens as this can distract the color perception. Randomly arrange the loose colored caps in front of patients before starting the test to prevent the memorized or pattern recognition. The patient must arrange the caps in sequence, grading based on the preserved hue similarity. After the initial arrangement, they should carefully review the sequence and make arrangement as needed. Documentation. Record the final order of caps of the FM100 or D15 score sheet of our analysis. The patterns of error can help to detect the type, example proton, deuteron, and triton, and the severity of color vision deficiency. Errors are made whenever caps are misplaced from the correct order. Error scores are calculated according to the distance between any two caps. The scores of each cap are plotted on the circular graph provided. By plotting the scores in the graph, it is seen that the characteristic patterns are obtained in the specific defect. Sum of the error scores of the entire set of the cap scores to make the total error score. Interpretation. The major rings of the graph indicate 2, 5, 10, 15, and 20 error points. The perfect graph will be circled on the second ring. The minor areas within 5 rings is acceptable. Large influence spike towards the quadrant are and indicate the color vision weakness in those colors. Interpretation of total error score. Color discrimination superior is 0 to 20, average 20 to 100, and low more than 100. Transmut T15 test. The test consists of 16 caps with a different colored paper. It separates patients into those with a mild to severe color defect who pass and those with moderate to severe defects who fail. Advantage and disadvantage. Ishwarya is insufficient for grading and monitoring color defects. Ones with Wilson D15 test can grade color vision problems and detect blue, yellow, and red and green deficiency. D15 is more sensitive to photon loss. D15 is less sensitive to subtle color vision defects, allowing milder red and green deficiency defect to pass D15 but fail Ishwarya. D15 should not be used in screening test as passing Ishwarya is the common requirement of the some profession. Test useful depend on the role of entrance environment to a certain professions. Procedure. Similar to FF100 hue, ask the patient to arrange the caps in equal gradient based on the hue similarity started from the answer cap. Allow the patient to review the arrangement and make any adjustment to ensure accuracy. Document the final arrangement of caps on the D15 score sheet. Analyze the sequence of crossing or errors to determine the type and the severity of deficiency. Example photon, deuteron, or titan. Interpretation. We have the D15 sheet. We enter the patient arranging orders in the back with the numbers. We connecting the dots. In the connecting orders, dots will be parallel to the dotted proton. The patient has proton deficiency. If connecting dots, the dots will be parallel to deuteron. The patient has deuteron deficiency. If the patient parallel to the triton, the patient has triton deficiency. Thank you.
Thank you so much, Renose. It was a wonderful presentation. Now I request our moderator to add your valuable inputs, ma'am.
Yeah. First of all, thanks to Agarwal team, thanks to Anshika and the whole team for inviting me to the session. And Renose, you have presented well. You have extremely covered all the major points. So I'm thinking what to cover now. Okay. So few points, what I like to test is because the color vision is the most important visual function. Basically, it's in clinical setup, we check only the high contrast visual acuity. These visual functions are not measured because of the time constraints. Only on request, when consultant is requesting or for any particular case, if we see any ocular disease case, then we will check the visual color vision here. There are many tests, so each test needs a special documentation and recording, and the procedure is also varies. Okay, so I would like to share few points. Can I share my slides?
Yeah, ma'am. Tell me if you face any problem, ma'am.
Is my slide visible?
Yeah, ma'am, it is getting shared.
So first, I just wanted to, as she has covered many points, I just wanted to differentiate. Before moving on to the procedure, you should know whether the color vision defect is a congenital anomaly or it's an acquired anomaly. So there are two different terms we say, anomaly and nopia. Anopia. So anomaly means it's a partial defect. Anopia means it's a complete defect. Okay, so we will differentiate congenital and acquired color deficiency. So congenital means we all know it's a hereditary, it's inherited. So it's genetic, cause is genetic, and acquired later on stages where it causes because of any systemic condition or ocular or any drug toxicity. Onset congenital is from birth, and you all can see, right? It's a, yeah. Okay. And the most diseases like what do you say? Type is red-green defect uh, in congenital, and it includes blue-yellow total color blindness in the acquired side. Progression congenital will be same. It is stable. It will not progress or it does not worsen. But in acquired diseases, based on the disease or the condition, it keeps progressing. And congenital is symmetrical in both eyes. Okay, but acquired deficiency can be unilateral or asymmetrical between the eyes. These are detected through a screening test. Okay, and the prevalence is more common in males for the congenital and acquired deficiency. There is no gender thing. It depends on the underlying cause. Any gender can be affected. And one more thing is what we say is what are the types affected? Mostly cones for protonomia, L cones for protanopia, and M cones for deuteranopia. But in acquired deficiency, it can be diffuse or specific cone retinal damage. And the treatment, there is no cure for the congenital deficiency. We will cannot manage. Only we can give some color filters or exchrome contact lenses. But acquired deficiencies, it will be improved by the underlying condition based on the severity of the disease. When we treat that disease, then the deficiency can get corrected. So common causes, you all know, as she also covered many of the diseases like drug toxicity, multiple sclerosis, CSCR and all. And moving on to the specific condition, right? Specific test. She covered many things about pseudoisochromatic plates. So I just wanted to ensure here she has already shown this slide. So I just wanted to ensure here is the luminance of the test. Okay, the luminance is very important. Usually we try to do it in a daylight. Actually, a daylight simulator is required. That is very expensive, so we cannot get it in all the clinics. So at least we should try to keep 250 to 600 lux, or if it is in Kelvin, greater than 5000 Kelvin should be there for the color vision test. Illuminance is very important, and distance is very important. Mostly everyone do at 35 centimeter based on the near vision correction. Okay, so that is wrong. For pseudo isochromatic plates, it is 75 centimeter. For HRR, it is 75 centimeter. If it is a D15 test, then it is 50 centimeter. Okay, so the distance varies. That you should keep in mind when you're checking the isochromatic plates. And mainly the recording is very important for all the color vision tests. So here we although check 38 plates, right, but which recorded for 25 by 25 or 16 by 16 correct responses, and you should record it monocularly, OD and OS. And pseudo isochromatic plates are mainly for to pick the congenital defects, not the acquired defects. For acquired defects, you take D15 plates. Okay, D15 or FM100 hue, that can be tested for the acquired deficiencies, but pseudo-isochromatic plates are for the congenital anomalies. Okay, and this check only red-green defect. Whereas HRR, that is also similar to pseudo-isochromatic plates, but it tests both the red-green defects as well as the blue-yellow defects. Okay. So this is the test she has shown, the scoring sheet. So here I would like to show you the scoring sheets. We also have the HRR, all can see, right? You have plates, so you should do it under a room illumination. You cannot use any incandescent or tungsten lamps because the yellow filter may influence the results, test results. Okay, so always try to use a good light illumination. So here, this is little difficult. Everyone will get confused in the HRR. Many will go with the pseudo isochromatic plates only. But here, what you should do is you have a 1 to 4 demonstration series. So that series plates, you need not score that. Okay, so that you can show for understanding purpose. You can show which there are plates where they can see the numbers. I don't know whether it is clear or not. You have a O pattern or a triangle pattern. So the patient has to say whether the pattern is in which quadrant. Either it is in the upper quadrant or lower quadrant. Okay, and then there are 6 screening series where 5 to 10 plates are called a screening series. So here the 5 and 6 checks the blue yellow defect. Okay, if you find any problem with the 5 and 6, you can directly go to 21 to 24 plates which test the degree of the blue yellow defect, whether it is a medium defect or a strong defect. Blue yellow defect, medium, strong or mild defect, extent of the defect is seen. If the patient is responding 7 to 10, if they are not responding properly 7 to 10, then you have to go to the go and check the 11 to 20 plates. plates number 11 to 20, and based on their responses you have to give a tick mark, either proton or deuteron. Okay, so that is how you have to count and do this HRR series. After demonstration, if the subject or patient is responding to all 5 to 10, then you can stop the test. That is normal. So interpretation is the patient is normal with this HRR color vision test. Okay, so here the recording is very important. You have to score it accordingly, and this can find the extent of the disease, whether it's mild or medium or strong. Okay, and one more thing is, even in pseudo isochromatic plates or D15, after recording you should also mention whether it's a normal color vision or any defect is there. You should not leave only with the responses, 16 by 16 responses. Okay, you have to mention whether it's a red green defect, 4 plates missed, what are the plates missed, and you have reassured the patient regarding the color vision defect they have, and so that you can also advise them for the further carrier options. Okay, that is very important to mention in the color vision recording documentation part. Okay, not only with the responses you should leave. The next one is D15. So this is the test plate we all have. You can test it either monocularly or binocularly. Mostly we do with the monocular thing, and test date is important to mention. And this is how, as she also showed this score. So I just wanted to show a few different patterns of this score. So when there is you have to record it from 1 to 15. If it is normal, then if it is in a full circle, then it is normal. If 1 or 2 caps are missing or interchanged, you can repeat the test and see. Maybe they would have taken a long time, or you can repeat the test and see. Okay, if you are repeating, then it is okay. So you can see here, it's a normal or a near normal session. And based on the color codings, whether it is protanope, deuteronope, strong, buten, so that is very important to note. What is the extent of the diseases? What is whether it is a protanopia, whether it is a tritanopia, or it is a deuteranopia. So that can be picked up with the help of D15 test. So scoring is very important. And the one more thing is, you should not give more time for them to see. Okay, and this D15 should be done in a black background, where you keep a black color cloth, and then you can keep the D15 test scoring plates, and then they will arrange the orders. First you should give a reference cap, and then you have to arrange. All the procedures are done with the near vision correction. If the patient is having any near vision correction, okay, with the correction only you have to do this. This is one thing I just wanted to say. And one more is, this is City University test. This is the scoring sheet for City University. So here also what you have is, you have a central color and surrounded by 4 colors. So the patient has to match whether the central color is matching with any of the 4 colors, and they have to point out whether it is up, down, left, or right. That is how, whatever they are pointing, you have to record it in a scoring sheet. So documentation is very important. Though we know the procedure, we miss in the documentation part. So I just wanted to ensure these are the documentation part where you nuancely record it. Okay. One more is the common errors what we do. These are the common errors in the color vision test. So using an inappropriate light source, which I already said, believing that D15 test means that the patient has a normal color vision. If the patient is responding for the D15, if everything is passed, don't assume they have a normal color vision. Sometimes pseudo isochromatic plates, they will have a pass, and D15 there may be a fail, or a D15 pass, maybe it's a mild defect, so that's why D15 is pass for them. And allowing the patient too long to look at the figures for City University test or pseudo isochromatic plates, anything, it's only 3 seconds. Within 3 seconds they have to flip the chart and then record it. Okay, and suggesting to the patient which spot might be correct. This is for City University test. Okay, and then is attempting to assess an acquired color deficiency using only the Ishihara test. So in Ishihara, it's for color vision. It is not, we also do for the acquired deficiency using the Ishihara test. So that is a common error we make. And these are tests which is used for some specific professions, right? So if consultant asks for latent test, but we do it in pseudo isochromatic plates, that is not proper. So whatever profession, what color vision test is used, the same test procedure you have to implement it on it, because color vision is very important for different occupations. She has also covered all the occupations: aviation, painting, chemical industry and all. So that is very important. Even India has some standards, like what are the color vision deficiency things. Okay, this is a small comparison between all the tests. I think she has missed Dalton color vision test. That is also similar to pseudo isochromatic plates. This is how the plates are. Dalton color vision, same. You have a diagnostic plates where you have 6 sets of color vision tests, 6 sets, and any one set you can check if the patient is one set is one out of 6 sets. Each set has 4 plates. So one plate is demonstration plate 12. If the patient is reading that 12, then fine. If the other plates are missing, then you have to repeat the other sets. Okay, that is how Dalton color vision test, same as pseudo isochromatic plate. So a small comparison between all the tests, the principle of pseudo isochromatic, HRR, Dalton, or same color confusion. D15 is for the hue or discrimination test, where D15 FM100 hue come. City University test, match central surrounding color, and Nagel anomaloscope is a color matching test. Purpose of all these tests is screening test for pseudoisochromatic. HRR and D15 assess the severity of the type. Testing distance is 75 centimeter for pseudoisochromatic and HRR plates. D15 is 50 centimeter. City University test is 35, and Delta color vision is the 50 centimeter. All the lighting conditions are very important. But in Nagel anomaloscope, there is an inbuilt lighting condition, so you can use that. And usually everything should be tested under a monocular thing condition. Okay. And this is the this is from a recent article published, where what are the categories required for different occupation, and what color test is required. So each color vision, there is a procedure, interpretation, everything given, instructions given. So when you're performing the color vision test, please read all the instructions carefully and then go ahead in performing the test. So I think these are the things I would like to cover based on the presentation. Whichever she missed, I think I have covered that. Okay, any other questions you can ask?
Thank you so much, ma'am. It was an elaborative discussion about what and when as to we perform the color vision testing. From the student's perspective, just to know what do we miss by neglecting color vision testing in a day-to-day or routine examination?
So day-to-day life, mostly contrast sensitivity and visual acuity, if it is less, we come to know. Okay, but color vision only by evaluation. Difficulty is for identifying the clothes. We cannot identify the day-to-day activities, even smell. Even if we are in a healthcare profession, when we know diagnostics, OCT and all, it needs a color vision to interpret the reports, right? Even medical practitioners to test the samples, if there is any skin rashes, to identify the colors, that is very important. So day-to-day activities will also get affected if the color vision is not proper. So one thing is important, how do we check in children? Color vision in children. So for them also, you can give some matching cards or matching shapes, and then ask them to match and say what color it is. Okay, teach them with the shapes. If the child is visually impaired and all, you can teach them with the shapes. Because visual impairment, color vision is also impaired. How do they identify their clothes and all? So as a part of rehab, you can just ask them to keep different shape buttons in each dress. If it is a circular, it is red color. If it is triangular, it is blue color. Something how they can touch, they can use their form sense, touch and see. So that is how for children it is useful. Okay.
Thank you so much, ma'am. In your regular practice, what are the common mistakes that the students make while testing color vision, ma'am?
Main mistake is distance, and they give more time to read. Okay, that is the distance mistake they make. When we ask, they say, ma'am, it is 35 centimeter, 30 centimeter. Then we say, go and read and come. Then they say, okay, it is 75 centimeter. No one will measure the distance. Here in our clinic, we always tell, use a measuring tape to measure the distance. And then with the measuring tape, and then they will do it. Sometimes lighting is also important. Glare. If there is a glare, then it is difficult. Okay, they test binocularly. It depends. So some errors they make.
Thank you so much, ma'am. That is one of the important point in which we have to advise students to look for. The next one
Yes.
is, what are color vision standards, ma'am? And do optometrists require color vision standards?
Color vision standards like optometrists require or recommend.
They by themselves for the job, do we require color vision standards?
Yes, as I said, yes, we also require a color vision standards because interpretation, I said corneal topography, OCT is there, fundus fluorescence angiography, even to see the retina, optic nerve, disc and all. So hemorrhages, to pick up hemorrhages, yes, as an optometrist, we also require color vision. Okay, but even Indian standards or government has some standards. If there is a mild color vision defect, they are advisable for these professions. Strong defect, they are not at all advisable for Air Force, Navy, aviation, and all. So there are standards.
Thank you so much, ma'am. So that is about the Q&A session. Over to Gomuti.
Thank you so much, Meenakshi. Thank you so much, Dhavamathi ma'am. Thank you so much
Thank
for the
you.
extra efforts that you have taken to present it in a presentation, ma'am. That was in a very detailed presentation. Thank you so much.
Thank you. Thank you so much.
We would like to host you on another wonderful platform, ma'am.
Thank you. Thank you.
Thank you, ma'am. Thank you so much.
Thanks for this opportunity. Yes.
Thank you so much, Meenakshi. That was wonderful presentation, Renose. With this, we're coming to the conclusion of today's episode. So we have an announcement for the week. The low vision workshop is coming up on December 7th. I'll give the link for the registration in the description box. Please go and register for the low vision workshop and we'll meet you in the low vision workshop. So thank you all so much. Thank you for your continuous support towards Optometry series. If you like this video, give a thumbs up and share with your friends. We'll meet you in the next episode. Thank you, ma'am.
Thank you.